Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast, your top free source for on-the-go board review. The topic for this episode is non-cancerous lesions of the breast. I will be covering specifically breast lesions that I believe are high yield for radiology board examinations. One quick reminder to follow at RadRevPodcast on Instagram or Twitter, where I am currently posting on a near daily basis tips for the physics portion of the ABR core exam. Without further ado, let's get into the questions and answers for this episode. First question, what are typical imaging features of an intraductal papilloma? Characteristic imaging features of a papilloma include a smooth-walled nodule in a dilated duct with a vascular feeding stalk on color Doppler imaging. Note that for the ABR core exam, papillomas, although benign, should be excised as they are considered high-risk lesions. Also, remember the difference between a central and peripheral papilloma. To keep it simple, central papillomas are more anterior in the breast and much closer to the nipple. A peripheral papilloma is more posterior in the breast, and that's one way you can remember this is the P for peripheral and the P for posterior. Peripheral papillomas are less likely to present with bloody nipple discharge and unfortunately also more likely to be both multiple and associated with cancer because those peripheral papillomas are more closely associated with the terminal ductal lobular units, which are in the more posterior ductal system. In comparison, a central papilloma is more likely to be solitary and more likely to present with spontaneous clear or bloody nipple discharge, and one way I remember that is because central papillomas are simply in the more anterior breast and in closer proximity to the nipple. If that papilloma becomes irritated and leaky and starts having serous or bloody discharge, it is much easier for that fluid to enter and exit through the nipple. Next question. What are typical imaging and clinical manifestations of diabetic mystopathy? Diabetic mastopathy usually manifests clinically as a hardening or thickening of both breasts in a patient with long-standing diabetes, which is historically classic for type 1 diabetes. But given the higher numbers of type 2 diabetes compared to type 1 diabetes in our current society, diabetic mystopathy cases may perhaps now be seen equally or even potentially more commonly in type 2 diabetics. However, I hope that a board exam will not ask you which is most common in terms of type 1 or type 2 diabetes for diabetic mystopathy, because the historical answer to this question has been type 1 diabetes is most common, although in reality this may no longer be true. Diabetic mystopathy usually involves both breasts and classically consists of a diffuse fibrotic reaction of the breast tissue with lack of skin involvement. Next, what are several classic breast lesions that can arise in the setting of lactation? I would propose that at least 3 breast lesions are commonly tested in association with lactation. The first is a galactocele, second, lactating adenoma, and third, simply a breast abscess. Let's start with galactocele. Galactoceles demonstrate fat fluid levels on mammography, ultrasound, and MRI. The layering fluid levels are key to diagnosis, wherein the less dense fatty fluid will be seen on top of or floating on the more dense fluid within an expanded duct. Essentially, this will look like a cyst with a fluid level. You should have some clinical history leading you towards recent pregnancy or lactation, and you can confidently say this is a galactocele. Next, lactating adenoma. A lactating adenoma appears the same as a fibroadenoma, with typical features of a circumscribed hypoechoic oval solid mass. Lactating adenomas are thought to be most common late in pregnancy or early lactation, and lactating adenomas are really a pathologic diagnosis, and you cannot distinguish definitively on imaging between a fibroadenoma or a lactating adenoma. However, if you are presented with a mass that looks a lot like a fibroadenoma and you are told a history of lactation or pregnancy, I would have a lactating adenoma high on my list of possibilities. Next, abscess. Lactation simply increases the risk of developing a breast abscess. Look for the characteristic heterogeneous, complicated fluid collection with signs of infection on clinical examination, to include redness, warmth, erythema, and skin induration, and imaging findings including robust peripheral vascularity around the heterogeneous fluid collection on color Doppler imaging. Remember that treatment of a breast abscess can include antibiotics, particularly if the abscess is very small, but if the abscess is larger, oftentimes aspiration may also be necessary, which can be performed with ultrasound guidance. Next, performing a core needle biopsy in the setting of lactation poses what unique risk compared to a procedure in a non-lactating individual? The top risk to be aware of when performing a core needle biopsy on a patient who is lactating is the risk of developing a milk fistula, in which milk can leak from the biopsy incision, which prevents healing, and over time you can form a fistulous tract from which milk leakage can occur. Many milk fistulas will resolve on their own, but others may require cessation of breastfeeding in that breast in order for the milk production to stop and the fistulous tract to therefore close off and resolve. Next, what are some common causes of gynecomastia? Common causes of gynecomastia include a relative imbalance of estrogen and testosterone, which in younger age groups is more likely to be elevated estrogen, and in older age groups the cause is more likely to be low testosterone. Contributing factors include many things such as renal and liver failure, many medications, which are classically several blood pressure and psychiatric medications, as well as substance use to include marijuana use, as well as heavy alcohol use. Remember that the first examination for gynecomastia would typically be a mammogram, and you are looking for that characteristic flame-shaped density that is seen in the direct retroareolar region behind the nipple. Next, what are characteristic features of a sebaceous cyst on mammogram and ultrasound? A sebaceous cyst is an inflamed hair follicle and most classically will be seen as a hypoechoic intradermal collection with a skin tract extending from the dermal base collection to the skin's surface. On mammography, this should appear as a very superficial lesion and may be inseparable from a skin lesion. On direct visual inspection, one usually sees a superficial bluish to dark punctum on the skin surface with an underlying superficial palpable mass. There may be redness, pain, and warmth in association with the sebaceous cyst if that sebaceous cyst is inflamed or infected. Treatment of a sebaceous cyst often comprises things like warm compresses placed on the skin that may help open the pores and promote drainage of the sebaceous cyst. Let's move on. What are characteristic imaging features of granulomatous mastitis? This is in many ways a trick question, as there really are no typical features of granulomatous mastitis, and this can present similar to a mass or similar to breast infection and has a multitude of findings. remember that granulomatous mastitis is a non-infectious process and is not an imaging diagnosis technically, but is a clinical and pathologic diagnosis. Granulomatous mastitis can be bilateral and can have draining skin fistulas with drainage of pus despite being non-infectious. The origin of granulomatous mastitis is basically unknown, and the clinical presentation can include a distinct palpable mass, and granulomatous mastitis is more common in younger women and may be associated with recent pregnancy. Primary treatment of granulomatous mastitis is often surgical and includes excision of the area of involvement within the breast. Corticosteroid therapy may also be considered in the setting of granulomatous mastitis. Let's move on. What is the classic diagnosis for a cord-like palpable mass in the superficial breast that may be red and painful? This clinical presentation is very high yield, and the entity I am getting at is mondor disease, which is a superficial thrombophlebitis that may be idiopathic or post-traumatic in etiology. Remember, the thrombophlebitis of the subcutaneous veins in the breast is classic for mondor disease. On mammography, you sometimes can see mondor's disease as a tubular structure in the superficial breast, and on ultrasound, you look for a vascular tubular-like structure that often has a beaded appearance and classically will show no vascular flow on color Doppler imaging, or else you may see a portion of the vessel as being patent and a portion being thrombosed. Treatment can include things like NSAIDs or other anti-inflammatory medications, and often this is a self-limiting condition. Next question. How can one distinguish a phylloides tumor from a fibroadenoma on imaging? If there are any breast imagers out there or others who are highly invested in breast imaging, you may have noticed your blood pressure go up slightly, wondering what I'm going to say, because the truth is that one cannot tell the difference between a fibroadenoma or a phylloides tumor on imaging. So, if you thought you could tell the difference, the take-home message from this question is that you, in fact, cannot tell the difference between a fibroadenoma or a phylloides tumor on imaging. In general, phylloides tumors tend to be larger and demonstrate more rapid growth compared to a fibroadenoma, but still, definitive diagnosis is not possible on imaging. Diagnosis is even often challenging on a core needle biopsy. An excisional biopsy may ultimately be required for definitive diagnosis of a phylloides tumor. Once diagnosed, treatment, especially for board exam purposes, is wide surgical excision, even if the phylloides tumor is benign. The classic age range for onset of a phylloides tumor is something like 40 to 60 years of age, which is a slightly older population compared to a fibroadenoma. However, breast imagers do see phylloides tumors in younger patients, so don't hang your hat on age alone. But perhaps age could help nudge you in one direction or another on a radiology board examination. Surgical excision is performed as a phylloides tumor is a locally invasive tumor, and phylloides tumor may be benign or malignant. And another key point for board exam purposes is that local recurrence is somewhat common, and if you have a malignant phylloides tumor, it is most likely to spread hematogenously, which means the axillary and internal mammary lymph nodes may be uninvolved, yet you may see metastases to areas such as the lungs. Next question, which is a short, simple question. What breast lesion is classic for a breast within a breast appearance? The answer here is a hamartoma, which is also sometimes termed an fibroadenolipoma. If you don't know what that breast within a breast appearance looks like, please look it up. It is high yield, to know what a breast hamartoma would look like. In general, this should look like a fairly well-circumscribed mass with a capsule, and within that capsule, you would expect to see fat density and soft tissue density components. Again, look this up if you don't know definitively what this looks like, because I would not be surprised at all if you encounter questions on hamartomas of the breast on radiology board examinations. Let's go on to the final question for this episode. A radial scar presents most classically with what imaging appearance? And a radial scar is classically at risk for harboring what type of malignancy? On mammography, a radial scar may look like a spiculated lesion or an area of architectural distortion that classically may not have a central mass-like density, although you cannot definitively differentiate between a radial scar or malignancy based on mammography. Some sources have reported that a radial scar is more likely to have a lucent area within the center of the spiculation or area of apparent architectural distortion, whereas a breast cancer is more likely to have a central mass. That appearance of a spiculated lesion with central lucency has been termed the dark star appearance, and that is something that you should be aware of, although, again, you cannot differentiate between a radial scar or a malignancy on imaging alone. Radial scars tend not to have a lot of really robust ultrasound findings, but you can see sonographic distortion at an area of the radial scar. A radial scar is considered a high-risk lesion, and so for board exam purposes particularly, surgical excision is recommended. In something like a quarter of cases, a radial scar can be associated with ductal carcinoma in situ or tubular carcinoma of the breast, and I would definitely remember that association between a radial scar and a tubular carcinoma. Also remember that tubular carcinoma is often thought to have a good prognosis compared to most other types of breast cancer. Finally, let's quickly discuss a complex sclerosing lesion. A radial scar and complex sclerosing lesion, according to my understanding, are essentially the same process, but a complex sclerosing lesion could be used for the lesion if it is over something like 1 to 2 centimeters in size. So I remember a complex sclerosing lesion as typically being a larger form of a radial scar. I do not think they would ask you on a board examination to distinguish between a radial scar and complex sclerosing lesion, as there is even some confusion about this topic amongst breast specialists. Nonetheless, good to be aware of both entities. That is enough for now. Thank you for listening to this episode. I hope this was helpful for many of you. I will make a free downloadable study guide on this topic available on my website, theradiologyreview.com. Look for the link to study guides, and you can find the free downloadable study guide for this and other episodes available there. Keep up the good work. Study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.